Hello, my name is Jenny Niedenfear. I'm a current second-year student at the University of Florida, a soon-to-be PhD student at the University of Texas Health, and also a patient advocate with the International Society for the Study of Women's Sexual Health. I'm going to be presenting on pelvic floor conditions, as well as the barriers to healthcare that patients may receive when seeking treatment for these conditions. I'm going to begin by providing a quick summary of each condition. These should not be used as full diagnostic criteria. Always make sure to seek out a health provider if you have any questions or concerns regarding any of these issues or treatments. Then I'm going to move on to discussing barriers to healthcare for most patients, also provide guidance for patients on how to best advocate for their symptoms, and then also provide guidance on how providers can improve their care towards patients with a trauma-informed approach during exams and consultations. So the majority of these conditions I'm about to discuss have many causes and contributors. Dyspareunia is characterized by recurrent or persistent genital pain before, during, or after intercourse. It was indeed believed to be purely psychological at one point, but now thanks to research efforts, we are beginning to understand the etiology and causes of various pain symptoms. Sexual pain is the main contributor of much interpersonal conflict and distress, and there are many root causes of this issue, so therefore it really is not a good diagnosis. It's characterized by superficial, which refers to the vulva or vaginal entrance, or deep, which means that the pain refers inside the vagina or the lower pelvis. Dyspareunia is also characterized by the onset of pain, which is either primary or secondary. Primary begins at the start of intercourse. The individual with primary dyspareunia has never had pain-free intercourse ever, whereas secondary occurs after an individual has already experienced a period of pain-free intercourse. So next we have vaginismus. This condition is not the same as hypertonic pelvic floor and is characterized due to the involuntary muscle spasming of a person with a vagina that prohibits sexual intercourse, fingering, dilation, speckling exams, or tampon insertion. This is not in the individual's control. It has a higher rate of success in treatments with pelvic floor physical therapy, cognitive behavioral therapy, and home exercise regimens with dilators. However, it is misdiagnosed due to the provider failure to assess the vulva in its entirety. Oftentimes, providers will bypass the vulva and go right into the vagina, where many crucial aspects can get missed, such as assessing the vulva. So this brings me to the next condition called vulvodynia. In 2015, a new terminology for vulvar pain and vulvodynia was adopted. It is now defined as vulvar pain that occurs for at least 3 months without an identifiable cause. When I refer to the vulva, I'm referring to the clitoris, the labia majora, the labia minora, and the vulvar vestibule. These parts of the vulvar anatomy frequently get missed during exams and should be more focused. The prevalence of vulvodynia is reported as affecting 8 to 16% of all people with the vulva across various age groups and ethnicities. This number is believed to be much higher, as many people are dismissed or misdiagnosed. It's characterized by the following descriptors: localized, provoked, temporal pattern, and onset. Some of the common symptoms that patients describe with vulvodynia include burning, stinging, shooting, and lacerating pain. Patients also describe difficulty with insertion, sexual intercourse, vulvar and pelvic examinations, orgasms, and clitoral stimulation. Some patients may also have difficulty with wearing jeans and tight clothing. So next is vestibulodynia. I'm not going to go over all the subtypes in depth, but I will provide links for you to further investigate these conditions. Vestibulodynia is defined as pain localized to the vulvar vestibule. You see here in right in the red, we have the vulvar vestibule. It starts beneath the clitoral hood, surrounds the urethral orifice, surrounds the vaginal opening, and it goes all the way down to the Hart's line. It has subtypes and causes that are not necessarily notated in the 2015 consensus, but they are recognized among the major providers in sexual medicine. Congenital neuroproliferative vestibulodynia. Neuro refers to nerve, and proliferative means replication of nerves. People with this condition are believed to have up to 10 times more nerve endings in the vulvar vestibule. Hormonally mediated vestibulodynia. This condition is believed to be caused by the usage of birth control, specifically combination pills, which contributes to changes in the hormone receptors and patterns in the vestibular mucosa. Acquired neuroproliferative vestibulodynia. This condition can show up later in life. It's also called secondary vestibulodynia. For this condition, the overgrowth of nerves can be caused by a chronic inflammatory response or an allergic reaction. So the gold standard for diagnosing congenital neuroproliferative vestibulodynia is a vestibular anesthesia test, also known as a VATS test. This is where the specialist will numb the vulvar vestibule with a strong compounding numbing cream. They'll tap lightly around the vulvar vestibule with a Q-tip with the cream applied. If the vulvar vestibule is fully numb, it can be a good predictor that you might have relief from a surgery called a vestibulectomy. This is an outpatient procedure where they will remove the vulvar vestibule. If the test induces pain or the vulvar vestibule is not numb, the vulvar pain may be a result of some underlying cause, such as a nerve-related issue, a spine-related issue, or hip-related issue, and that further testing is indeed needed. Vestibulectomy may not be your best option if you do have pain in the vulvar vestibule after the cream is applied. So this is just a quick depiction of the differences between localized vulvodynia, vestibulodynia, in comparison to generalized vulvodynia physically. We see here that generalized vulvodynia encompasses the entire vulva, and it may have overlapping symptoms with pudendal neuralgia and other conditions. This is why having a solid diagnosis and thorough examination is needed by a knowledgeable provider, specifically a sexual medicine doctor. So next is hypertonic pelvic floor and hypotonic pelvic floor. It's important to differentiate between all of them to correctly assess patients so they can receive the proper treatments. So hypertonic is when the muscles are tense, tight, and unable to relax, whereas hypotonic is when the muscles are not providing enough structure to support the other surrounding organs. Many people with endometriosis, spine injuries, vulvodynia, vestibulodynia, pudendal neuralgia have hypertonic pelvic floor. Trauma to the pelvis from an accident, childbirth, or poor posture can also contribute to pelvic floor hypertonicity. Pelvic floor muscles may also be compensating for other issues like unstable hips, like hip dysplasia, femoroacetabular impingement, labral separation. People with a penis can also have pelvic floor dysfunction and the inability to relax the pelvic floor, which can also contribute to erectile dysfunction, hard flaccid syndrome, and urinary and fecal incontinence. So interstitial cystitis is a condition that affects the urinary bladder, and it's characterized by chronic inflammation. It is not secondary to an infection like a urinary tract infection. In many cases, it remains as a diagnosis of exclusion. The condition is often diagnosed late in the patient's journey. Patients often describe pain in the bladder region with a strong sensation to want to urinate known as urgency. This sensation is worsened by filling the bladder and is relieved by passing more urine, such as frequency. This may be during the daytime or during the nighttime, known as nocturia. And there may be other symptoms such as pain or discomfort on passing urine, known as dysuria, and pain or discomfort during sexual intercourse, known as dyspareunia. And due to these symptoms, there's an extreme and profound impact on the psychological, emotional, and social well-being of the patient. And on the right, we see Hunner's lesions, which are known to appear in less than 7% of the cases. These can be diagnosed with a bladder camera, known as a cystoscopy. Oftentimes, the providers will insert the bladder camera with a patient under twilight sedation. They'll fill the bladder up with saline solution and try to get a good look around the bladder. A bladder, though, without these lesions, does not exclude them from having IC. So endometriosis is a chronic inflammatory condition where the endometrial-like tissues grow outside the uterus. It is not the endometrial lining, which is a source of confusion for many. It has many different treatments, many theories, the most common one being Sampson's theory of retrograde menstruation. It has been found in every single part of the body as of 2022 and can contribute to infertility. The symptoms range a lot from chronic pain, abdominal bloating, fatigue, constipation, heavy bleeding, and debilitating menstrual cramps called dysmenorrhea. So treatments can help manage the disease, like birth control, diet changes, and pelvic floor physical therapy, but they are not always effective. So there really is so much more research needed for this condition. The gold standard for a diagnosis is a laparoscopy, and treatment is excision, which is the removal of the lesions and adhesions with the use of the small incisions made with the laparoscopy. The laparoscopy can either be performed with the Da Vinci or the haptic method, however this depends on surgeon preference. Endometriosis is also characterized by stages 1 through 4, and stages do not correlate with pain. You can have stage 1 endometriosis, which has minimal implants and still have debilitating pain, or you can have stage 4 endometriosis with very minimal symptoms or even be asymptomatic, but you can also have many implants, severe cysts, and lesions and adhesions all throughout the body. So next is adenomyosis, which is defined as the disease where the endometrial glands and stroma insert themselves into the myometrium of the uterus. It is a very challenging disease to assess, identify, and even manage. It can be identified by imaging like MRI, where the junctional zone and endometrial stripe is measured, but also through myometrial biopsies for people who wish to keep their uterus. However, hysterectomy, the removal of the uterus, is the most invasive method of identifying and diagnosing adenomyosis. It's also the only method of curing the disease. At least 2/3 of patients will experience symptoms, the most common being heavy bleeding, clots, and cramping. During surgery, surgeons will identify adenomyosis as being a thick, boggy, and inflamed uterus. Although the disease generally appears in the late years of childbearing, people can also develop it earlier. Endometriosis and adenomyosis can coexist simultaneously. In a review by Gonzalez and colleagues in 2012, the author suggested that deep infiltrating endometriosis can be used as a marker for adenomyosis. I also wanted to mention that there are a number of conditions that have overlapping symptoms with endometriosis and adenomyosis that need to be evaluated and addressed properly. They all have unique ways of being diagnosed and screened. Again, this is not a comprehensive list, but can be very helpful. For example, the venous conditions like pelvic congestion syndrome, nutcracker syndrome, May-Thurner syndrome, the gold standard for diagnosis is a CT venogram with an interventional radiologist. So this brings me to penile dysfunction and pain. This would not be a complete pelvic pain condition slide without including penile pain conditions. We often hear about sexually transmitted diseases, erectile dysfunction, and ejaculation issues, but there are a number of conditions that often fall under erectile dysfunction, but they're actually incorrectly categorized or misunderstood. The one I'm going to focus on solely is hard flaccid syndrome for this PowerPoint. A number of patients are diagnosed with hard flaccid syndrome, but they actually all have very unique symptoms and characteristics. It is a very poorly understood and defined issue. While many of the current literature suggests it is characterized by a semi-rigid penis at the flaccid state, many still have erectile rigidity and mild to severe erectile dysfunction. This condition is most prevalent in the age group of 18 to 45 years of age. Many patients report having urinary symptoms, loss of sensation including numbness, coldness, pain at the base, bowel issues, lower abdominal pain, psychological distress, lumbar spine and sacrum pain issues along with clicking and rigidity, and pelvic floor muscle dysfunction. Symptoms are often exacerbated in the standing position and are relieved by laying down. And while the literature characterizes hard flaccid syndrome as being caused due to excessive masturbation, injury, trauma, stress, or muscular issues, getting to the root cause of each individual case will be much more valuable. So more research is truly needed to understand these complex multifactorial etiologies. Most of the information on hard flaccid comes from online forums, so these are some self-reported symptoms and issues. Many patients actually report having other comorbidities alongside hard flaccid, such as osteitis pubis, hernias, hip abnormalities, spinal issues, vascular issues, and connective tissue disorders such as Ehlers-Danlos syndrome. So next we have pudendal neuralgia, which is the irritation of the pudendal nerve from the sacral spine nerves S2 through S4, which can occur in both people with a penis and a vagina. It is bilateral and carries sensations to the clitoris, the penis, the labia majora, the vulvar vestibule, and the lower half of the vaginal canal, labia majora, and scrotum. Symptoms can include burning, tingling, and painful sensations that are debilitating to the point that people cannot move or even sit down properly. It can contribute to bowel, bladder, sexual, and autonomic pain. Diagnostics include electromyographies and nerve conduction tests that measure the electrical activity of nerves, and pudendal nerve blocks, and MRI neurograms. So there are a number of orthopedic and connective tissue disorders that can contribute to sexual pain, and these have yet to be thoroughly researched, like hip issues, labral tears, FAI, hip dysplasia, spinal issues, Ehlers-Danlos syndrome, which is a connective tissue disorder, rheumatological diseases, and mast cell activation syndrome. This is not a comprehensive list by any means, but it is a starting point and a foundation in understanding some of these sexual issues. For example, mast cells have been implicated in a number of other pain syndromes like endometriosis, vulvodynia, chronic pelvic pain, and migraines. So in this next part of this presentation, I'm going to be discussing patient barriers, trauma-informed care, how patients can best advocate for their symptoms and conditions, and also key takeaways. So this is a conceptual model for a scoping review that me, Dr. King, and Mary Edwards recently published, where we systematically investigated the literature from 2012 to 2022 on patient barriers for people with vulvar pain. And I recently presented the results to the International Society for the Study of Women's Sexual Health. I created this model that illustrates that there are a number of barriers that overlap and contribute to each other. So the majority of the studies focused on anxiety, depression, post-traumatic stress disorder, fear, catastrophization, and interpersonal issues among partners. Structural and environmental issues such as cost, dismissal, lack of transportation, and mistrust of health providers also contributed to mood disorders, and many of these barriers are associated with a decrease in help-seeking behaviors, resulting in delayed diagnoses and subsequent treatments. So my model clearly represents a perpetual cycle of barriers for patients, and for example, people may feel uncomfortable discussing their sexual pain with their partner, which may impact the relationships and lead to poor self-image, depression, anxiety, and isolation. Then they may go to seek treatment, which may be met with high costs, dismissal, and disbelief, leading to further anxiety and depression again, low self-efficacy, which in turn affects interpersonal issues. And really the cycle continues with this. So as a patient advocate, I do like to help patients learn tricks and methods to best advocate for themselves in the face of all these barriers that I just mentioned, especially the structural barriers. So I do recommend keeping a running list of all your medical history, updating it after every single appointment, as it is very hard to keep track of all your symptoms and history when you're constantly having appointments week after week and you're having to repeat it to all these providers in such a short amount of time. I recommend keeping all the doctor notes, imaging reports, CDs, blood tests, and surgical notes in one location. I like to have a Google Drive and I just keep uploading everything to one file. Reading the medical literature is also an important thing. As appointments are so short, it is really beneficial to read it to get an overview of conditions by reading online. Try to absorb as much information as you can in order to know what to ask in an appointment. You do have to have some basic understanding of the condition itself and the surgical procedures and the treatments to even know what to ask. And this is part of informed consent. Providers really do not have the time to go over every single little detail, so you do need to be somewhat informed prior to the start of the appointment. I also recommend trying to anticipate the outcome of the appointments prior to going in, just so you're not thrown off by anything. I also recommend patients joining online Facebook and Reddit health groups for support. There are a lot of good tips on there. And also I recommend taking care of your mental health. A lot of patients tend to get very stressed before going to a new doctor. This is completely normal. So do anything you can to take care of your mental health by talking to a cognitive therapist, exercising, treating yourself to a fancy meal, a sweet, anything that makes you feel better. So this is a bit of guidance on how to provide trauma-informed care for providers, specifically surrounding pelvic exams. So the pelvic exam, the vulvar, and the penile exam is a source of psychological stress, or can be a source of psychological distress among many patients. Consent is key here. Establishing rapport, asking for pronouns, and getting a good intake of someone's medical history are all really important. The exam does not have to take place on the first visit, and you do need to be asking for consent at every step of the way during a pelvic or vulvar or penile exam. So slow down during the exam, and that means going touch by touch, letting the patient set the tone of the exam, allowing the patient to ask questions, even utilizing mirrors, having their legs placed in different positions, not having them in such a high range of dorsal lithotomy, because that can put a lot of stress on the hips for people with hip abnormalities like hip dysplasia or connective tissue disorders. Allow patients to listen to music, utilize meditation or breathing exercises. You can even prescribe them anti-anxiety medication or relaxants like Valium or Versed. Those are great tactics in alleviating anxiety. Never discuss treatments while the patient is undressing or not properly clothed. We know that providers are quite busy, especially with the short appointments times, but slowing down the exam and taking your time can really make a huge difference for someone in the long run. Here are the key takeaways I really want to hone in on as I have now come to the end of this presentation. There are still so many gaps in medical care that are making it ever so difficult for patients to get proper care and even a diagnosis. Patients are still being dismissed, they're not being diagnosed, they're not being screened, and even their conditions are being dismissed as psychological. There are other disciplines that really need to be educated and involved in the treatment and care of certain conditions like endometriosis, vulvar pain conditions, and penile pain conditions. So having rheumatologists, orthopedists, radiologists, geneticists, and immunologists involved will be beneficial in the years to come, as these diseases have such complex etiologies. Having a provider that helps patients engage the root cause of their pain symptoms will also help pave the way for more treatment options and a reduction in pain symptoms. Recent studies have shown that successful surgical interventions are proven to result in decreased pain and decreased mood disorders such as anxiety and depression. Eliminating preconceived notions regarding sexual pain and reinforcing a general understanding that sexual pain is real and has a real physiological etiology will be important. So discussing these issues with family members, friends, and significant others will be helpful to break the stigma that pain with sex, pain with periods, bowel and bladder pain, and pain with pelvic exams are not normal in any means. More health education campaigns for sexual pain have been shown as effective in combating individual isolation and reaching diverse audiences, especially for those who live in underserved rural areas. Social media platforms have been shown as helpful in conveying information to both providers and patients. So that is the end of this presentation. I've provided supplemental readings and organizations to view at the end of this PowerPoint. Please do reach out if you have any other questions. I would love to hear from you. Thank you.